Hello everyone, I'm Sanathon Chalsin, the MSc student at UCL Ear Institute. I'd like to present the topic about evaluating the evidence for the presence of auditory processing deficits in autism. And this is the outline of my talk. I would like to start with briefly describe about auditory processing disorder or APD and autism spectrum disorder or ASD. Then I will provide the evidence for the presence of APD in ASD. Let's start with auditory processing disorder or APD. The definition of APD by BSA 2018 states that APD is poor perception of speech and non-speech sounds, and the origins of impaired neural function can be from both afferent and efferent pathways of the central auditory nervous system, and this includes both auditory and cognitive elements. To diagnose APD, patient need to do some tests, such as the specific battery test, which are the behavioral tests for several domains of APD, or the electrophysiologic measures. These pictures show that if the patient have the lesion or the pathology along the central auditory pathway, they can present with the auditory processing disorder. And APD may coexist in other disorders. These also include ASD. Now, let's move to the autism spectrum disorder or ASD. The definition of ASD is neural development disorder that is characterized by difficulties with social communication and social interaction and restricted and repetitive patterns in behavior, interests, and activities. Autism is spectrum because there is heterogeneity in presentation, severity of symptoms, skills, and level of functioning. To diagnose ASD, it is based on DSM-5 criteria or ICD-10 criteria, as you see on the screen. Now I would like to talk about the evidence of APD in ASD, and I will divide the study into three groups: the behavioral research, neuroanatomical research, and auditory evoked potential research. Most studies in this presentation are comparison between the ASD and typically developing controls. So let's start with the behavioral research. Let's start the behavioral research with the studies about pitch perception in ASD. The study that found ASD patients have superior pitch memory and identification, have more accurate at identifying the pitch, and more proficient at discriminating pitch. So from these studies, it can be concluded that patients with ASD have better pitch perception, including memory and discrimination. The superior pitch perception may be a consequence of reduced attention to linguistic information during development. Also, ASD patients have increased awareness of pitch change in environment, and that could potentially result in hypersensitivity to certain sounds and consequent stimulant overloads, and therefore it can make them impair processing for linguistic information. Now let's move to the evidence for the loudness perception and hyperacusis in ASD patients. Individuals with ASD have described certain sounds as being more intense than others. And there was a research that showed significantly lower loudness discomfort level to pure tone and increased loudness growth for moderate and high-intensity stimuli in ASD patients. Adolescents and adults with ASD are able to accurately discriminate intensity change from pale low-frequency simple to complex tone. And it was also found that loudness sensitivities decrease with age for autistic participants, and this is similar to the control data with time. To conclude about the loudness perception and hyperacusis, it can be concluded that ASD patients have enhanced loudness sensitivity, and it appears to decline with age. They also have the accurate performance on intensity discrimination task. The study about sound localization also show a typical orientation to the auditory information, especially to the spoken language. There are evidence found that children with ASD are less likely to orientate to their name from the age of 8 months to the age of 1 year. They are less likely to orientate to sounds in general, and they tend to turn their head to non-speech analog compared to motorists, while the control turn an equal proportion of time to both stimuli. Later, there was the study showed that autistic toddlers who oriented longer to motorists can exhibit better receptive language skills. In summary, this evidence showed the reduction of orientation to the auditory information in ASD, particularly to speech, and this may due to atypical processing of complex stimuli in ASD. About the hearing in noise ability, the study in 2009 showed that both ASD patient and control have more proficient at identifying words in the pink noise containing temporal dips. However, the gain in performance was significantly less in children with autism, and this can be implied that ASD children had reduced utilization of temporal dips. Another study in 2005 showed the significantly slower and less accurate at identifying the direction of target signals, and this can be implied that ASD patients have difficulties filtering out irrelevant auditory stimuli. So in summary of the hearing in noise ability in ASD patients have impaired processing of auditory stimuli and speech in background noise. So let's move to the second category, the neuroanatomical research. There are also several research about functional MRI or FMRI, and I'd like to start with the studies that showed the low activity. These studies use vocal or speech stimuli and showed lower activity in several regions, such as superior temporal gyrus, the left middle temporal gyrus, left medial prefrontal cortex, and left precuneus, left inferior frontal regions, and left frontal temporal regions, which is response to the complex listening task that require comprehension of semantic or pragmatic information. However, there are some studies showed the higher activity in fMRI. The study by Wang in 2006 showed stronger activation in the right inferior frontal gyrus and the bilateral temporal regions to ironic statements. And this can imply that the enhanced activation of these regions in ASD may serve as a compensatory strategy to facilitate processing of complex auditory information. Another study by Gomot in 2008 also showed the stronger activation of right prefrontal and premotor cortex, two complex tonal deviants relative to controls in pitch discriminating tasks. Individuals with autism were significantly faster at detecting deviant tones relative to control subjects. From the FMRI studies that I have mentioned before, it can be concluded that there is less activation of temporal and of frontal regions to passively present the speech or complex stimuli, especially in the left hemisphere. However, there is increased activation of right hemisphere at frontal and or temporal region to verbal information. And this can happen with or without weaker activation of left hemisphere language regions. All findings can be implied that ASD patients have different processing and or compensatory strategy. And now I would like to talk about the last group, which is the auditory evoked potential research. And let's move forward to the first subgroup, which is the brainstem evoked responses. There are some studies about ABR in ASD patients. This study used the fast and slow ABR click, and it found that when using fast ABR click rate, there was the significant prolongation of wave 5 latency in children with autism. However, when using the slow ABR click rate, there was no significant difference. And this can be implied that the slow ABR click rate may not sensitive enough to detect more subtle brainstem impairment in autism. Another study used the click ABR response with and without forward masking, and the study found that there was significantly smaller of wave 3 amplitude in adults with ASD in the forward masking situation. And this can be implied that the patient with ASD have impaired brainstem processing of the auditory information in difficult listening tasks. Another study was done by recording the speech evoked brainstem response. This study used the speech syllables in quiet and in background noise, and it found that children with ASD had less efficient encoding of speech syllables in noise and in quiet. There was impaired encoding of frequency and timing of speech sounds in quiet, with the smaller wave F amplitudes and greater overall waveform degradation of speech sounds in background noise. So from the study of ABR and speech evoked brainstem response, it can be concluded that ASD exhibit impairment of auditory processing at brainstem in both simple stimuli and complex social stimuli. Then let's move to the next one, which is the cortical auditory evoked potential. There are studies about P1, N1, P2, and A2 for the ASD patient, and the studies used non-speech stimuli and found that there was smaller N1 amplitudes and delay latency. And another study found that there was a prolonged latency and or smaller amplitudes of the early CAEP components. Other studies also used the speech or complex stimuli, and the findings from the study were smaller and or delay early CAEP components. This is an example of the study that have the smaller P1 and or N2 amplitude and significantly delay in one latency. The study about auditory mismatch negativity or MMN. When observed the MMN response to infrequent pitch modification, the study found larger amplitude and shorter MMN latency, and this can be implied that ASD patients have superior recognition of pitch change. MMN response is also observed to infrequent speech syllable, vowel, and consonant change, but the finding found delay and or smaller amplitude, and this can be implied that ASD patients have impaired recognition to change of linguistic element of speech. In the recent meta-analysis in 2020, it found reduced MMN amplitude and prolonged latency in response to speech sound, and reduced MMN amplitude but shortened MMN latency in response to tone duration deviance. The P3A subcomponent of auditory P300 is reported in several studies by using passive listening to speech and non-speech stimuli, and the studies found that there was smaller P3A amplitude or absent P3A. This can be implied that patients with ASD have reduced ability to involuntarily switch attention to speech. P3B subcomponent is also reported in several studies. The studies found smaller P3B amplitudes in active pitch discrimination tasks and infrequent speech targets. These can be implied that there is impairment of updating of infrequent or unexpected auditory information in context, and there is impairment of attention to unexpected auditory change, which consequently impairs updating of novel auditory information in memory. And this is the summary of studies about CAEP in ASD patients. There are evidence of central auditory processing impairment in multi-levels, including P1, N1, P2, and N2 complex, MMN, and P300. Patients with ASD probably have better pitch detection or discrimination ability. From all studies in this presentation, it can be concluded that ASD patients have central auditory processing deficits in various domains, such as speech, language, attention, or cognition. However, ASD patients may have better pitch perception and discrimination ability. And this is the reference of my presentation. Thank you.